Hello, everyone, and thank you very much for attending the 27th Annual IWMF Ed Forum. I'm Paul Kitchen, and I'm a WMer. I'm also an IWMF trustee, a member of the IWMF Audit and Finance Committee, and the International Committee Chair. We hope that you're enjoying the educational sessions offered on this year's two-day agenda and the expert faculty bringing you these stellar presentations. Just a reminder that the IWMF Networking Lounge is now open if you'd like to check out some WM community conversations. My mother, 40 years ago, had WM in the late 70s. And there was no treatment, and she withered away. And today, I live with the difference of the research we're doing. I've had 3 very useful and helpful treatments. This is why I'm so proud of the IWMF and the work it does. Now, it's my great honor to introduce my friend, Dr. Stephen Treon of the Bing Center of Dana-Farber Cancer Institute. The Bing Center is named after our friend Dr. Peter Bing, who is also a WMer. Dr. Treon has led the Bing Center for the last 23 years. 10 years ago, the IWMF hooked up with the Bing Center and sponsored research into the 300 project. What Bing Center did is they took the genome of 300 WM patients, and over this 10 years, the research has been phenomenal, revealing the outcomes and the progress of WM. And the amount of information that the Bing Center gets today from this is just fantastic. And it just shows the progression and new innovative interventions that we're inventing. I want to thank Stephen very much for all the work he's done over the years. I'm thrilled that he's here to join us today. Stephen?
Thank you, Paul, for that very kind introduction. And it's really a pleasure to be here today. I really wish it was live because nothing beats being together live. But during these circumstances, I think this still gives us an opportunity to be able to relay to our community all the great progress that's being made. I especially want to take a moment and just thank the IWMF. And when I say the IWMF, it's really a community that has come together. For the last 30 years, I've had the privilege of interacting with this community, which has grown in number, but also in purpose. And many of the great advances that we now see in terms of our understanding of this disease, but also the drugs that we've now brought in to treat patients with Waldenstrom were made possible because of this community. Its grant funding and support has enabled the discovery of the key mutations in Waldenstrom, which I know you've heard about already, but we're going to go over today. But it's also enabled us to be able to create a roadmap that will be delivering, for ages and ages to come. This roadmap, of course, now includes the likes of drugs like ibrutinib and zanubrutinib, which became the first drugs approved specifically for Waldenstrom's macroglobulinemia, not only here in the US, but Canada, as well as in Europe and many, many other countries across the globe. Tirabrutinib, which was recently approved in Japan, was made possible because of these discoveries. And you're going to be hearing about a lot of other BTK inhibitors, the likes of which are like acalabrutinib and pirtobrutinib, which are also emerging in various countries and offer new hope to patients with Waldenstrom. But you'll see also today how many new drugs yet await us. And so this is really the purpose of my talk today, is to acquaint you with all the discovery that's being made. Why? Because the IWMF supported the genomic discovery and now also supporting the multi-omic discovering, which I'm going to show you is indeed paying off. Before I start, I just want to share with you my disclosures to show you where my research support, consulting, and honoraria come from. And I think of all the slides I'm going to show you today, this is the one I'm most proud of. This is the slide that shows you sort of the signaling pathway that has been created around the discovery of the MYD88 mutation. This was discovered in my laboratory thanks to whole genome sequencing. It was funded by the IWMF as well as by Peter Bing and published in the New England Journal of Medicine. And at the heart of this article was the fact that the MYD88 mutation was found in over 90% of patients. Now we believe it's about 95 to 97% of all WMers. But then if you look at this diagram, which is very complicated, I think, take a moment to really come away with the fact that this took many years of work to create, but it gives us a very detailed electrical diagram or circuitry board, if you will, of how MYD88 functions in Waldenstrom cells. And there have been some key discoveries here since we last spoke a year ago. So at the top there, you see that MYD88 is shown. It's hanging on to this receptor called the toll receptor. This is a receptor that actually senses for various bacteria and viruses, because after all, Waldenstrom cells were immune cells, and they were initially geared to respond to infections. But when MYD88 becomes mutated, it fires off. And one of the key discoveries made in our laboratory, thanks to the work of Dr. Guang Yang, was that this molecule dead center called HCK becomes turned on. This molecule has no business at all being in a late stage B cell, which is what Waldenstrom is. And because of the mutation in MYD88, this gets turned on, and then look what it does. It turns on BTK. BTK, of course, is what we target with the various drugs like ibrutinib and zanubrutinib, acalabrutinib, pirtobrutinib, tirabrutinib, and others that are going to come. So this shows you why we're so excited about the development of BTK inhibitors. But also notice, and this is why it's important to create these very, elaborate diagrams from the work that has been done in our laboratories as well as others, to show you what MYD88 can do. It not only turns on BTK, but you can see it also turns on ERK. You see that to your left-hand side. ERK is very powerful. It's actually one of the molecules that turns on all kinds of inflammatory proteins, and it enables the Waldenstrom cell to gain a foothold in the bone marrow. And then look over to your right. Unfortunately, the pointer doesn't work on this platform for me to do it for you, so you'll have to look to the right, and you see this other molecule called SYK, S-Y-K. This is also a very powerful molecule. We just recently discovered, and we reported this in the journal Blood Advances. And HCK turns on this molecule, and look what it does. It turns on yet other circuitry that can enable the growth and survival of Waldenstrom cells. Now, the reason why I show you this is not only to depict how complicated MYD88 signaling is, but more importantly, to show you where therapeutic opportunities exist. I mean, if you don't know how the circuit's turned on, it's very hard to innovate new drugs. And I already talked about BTK inhibitors, but there's also ERK inhibitors that we're excited about. We're excited about HCK inhibitors, including KIN8194, a very potent inhibitor of HCK that the IWMF has provided funding to be able to enable its development. And then SYK, there's a number of molecules that have been developed against that molecule as well. And so either alone or in combination therapy, this is sort of the roadmap that we see going ahead for opportunities to treat Waldenstrom's disease. And I personally am very excited about HCK inhibitors because you see, after all, how high up in the totem pole HCK is, that if you're able to knock out HCK, you can actually damage the circuitry, the likes of which, would include BTK, ERK, as well as SYK, from being able to signal on and provide growth and survival cues. Now, there's also the other molecule, CXCR4. I know you've heard about this. This was also discovered in our laboratory thanks to the whole genome sequencing that was made possible by the IWMF and Dr. Peter Bing. And what is this all about? Well, about 40% of all Waldenstrom patients have this mutation. This is an interesting one because it comes in many different flavors. When you think about the MYD88 mutation, it's almost one particular type of mutation that's redundant, the L265P mutation. However, there are over 40 different types of CXCR4 mutations that we and others have discovered. And broadly, these come in two different families. There are the so-called nonsense variants, and there's so-called frameshift variants. Now, let me do a little bit of basic genomics here to tell you what the difference is. When you think about a nonsense mutation, this is where you're introducing into the DNA a stop codon. And what this orders is the stopping of manufacture of protein from that point on. It's like if you see a train going by and the mutation actually cleaves off the last 4 cars. This is what nonsense mutations do. When you think about frameshift mutations, think about that train. There's an order in how the, cars are all arranged, and way at the back there's a caboose. Frameshift mutations scramble the code, so all those cars get scrambled in their order. Both of these have consequences, but the one that actually appears to be the bad offender are those nonsense mutations where you've cleaved off a number of cars and you've lost them. This is the mutation like S338X that's typified here, which is typical of the ones that you see when patients come in with hyperviscosity crisis, when their IgMs are very, very high. And these patients don't respond to BTK inhibitors as well, including the likes of ibrutinib and zanubrutinib, which I'll talk a little bit more about in a moment. And so this kind of nicely summarizes that the different mutations, if you take into account MYD88 and CXCR4, can end up, manifesting themselves very differently in different patients. Patients will present differently because of the mutations they have. Let me also show you this slide. This is one that I'm also very proud of. It was also supported by the IWMF, and it was the work to try to understand how CXCR4 circuitry, works. And so just a little basic lesson, because 40% of those of us who are on here with Waldenstrom have this mutation. So I'd like you to at least know a little bit about this. So CXCL12 is a molecule that's made in the bone marrow by cells called the bone marrow stroma. They release this, and the CXCR4 is a receptor that's found on the Waldenstrom cells. And what this does is when these molecules bind together, they actually attract the Waldenstrom cells to the bone marrow. That's one of the reasons why people who have the CXCR4 mutations tend to have more disease in their bone marrow, because this is acting as sort of we call it a chemo attractant. It says, please come here. And it attracts the Waldenstrom cells to the bone marrow. But what it also does is it triggers this circuitry that's mediated by these molecules, AKT and ERK. This was also discovered in my laboratory. Dr. Irene Gobriel's laboratory has also done a lot of work on this. But the short of this is that when these molecules are turned on, they tend to mediate resistance against drugs like ibrutinib. And this is why we're also working these days on ways to disrupt this signaling pathway by using drugs that actually block CXCR4 signaling. And actually, we've been quite successful in being able to show in a phase 1 initial study that if you do this, you can actually sensitize the patients back to ibrutinib. And this is one of the reasons why, again, this is going to be one of those gifts that will keep on giving. The genome is teaching us a lot about the disease, and in particular of individual patients. As I talk forward from this point on, I want to acquaint you with the big questions that are out there in Waldenstrom's, the ones for which there's still debate among us as clinicians. We'll probably talk a lot about this during our Ask the Doctor session, but at least want to acquaint you with the idea that there are, a number of areas that still we need to sort out. The first is, when somebody's diagnosed, should we be giving them chemotherapy? Bendamustine Rituxan is perhaps the best example these days of chemoimmunotherapy, or should we be giving them a BTK inhibitor like ibrutinib or zanubrutinib or acalabrutinib? And then which BTK inhibitor do we give and for which patient? This is a big question because now all of a sudden we've been gifted with all these, drugs that target BTK. How do we manage the patient who's progressing on a BTK inhibitor? Now that's a big question these days too. And it isn't just the patient who's progressing, it's also somebody who's intolerant to a BTK inhibitor. And then how do we factor in the genomics in our treatment decision making? So I'm going to just sort of walk us through some of these questions and then, end up at the end talking a little bit about how multi-omics are going to help us. Now, I think all of you know that there are many different chemoimmunotherapy options. I'm not going to review these because I think, others before me did a good job. And they showed you that these drugs are very active, including the likes of Rituxan and bendamustine, which we use a lot these days, which can get a lot of patients into a response, but very seldom into a complete response. But nonetheless, why do we still want to innovate? Well, we want to innovate because these drugs do have a lot of side effects. And again, I won't get into the particulars today of talking about the various side effects that come with these drugs, but enough to tell you that they can have both short-term and long-term toxicities, including secondary cancers, which is why we're interested in finding new drugs that target Waldenstrom. And ibrutinib represented one of those therapeutic opportunities because of what we learned about MYD88's interaction with the molecule BTK that I showed you. And just as an update, this is the trial that we initially ran. I was the principal investigator of this trial of ibrutinib in previously treated Waldenstrom patients. It was a study that was given actually accelerated breakthrough status by the FDA because there was the mutation, there was the signaling showing that the mutated MYD88 turned on BTK, and there was initial activity of the drug that we had noted, which allowed us to go to the FDA and say that we have enough evidence that we want an accelerated breakthrough designation, and we got it. And I want to show you the trial. This was a trial that was initially published in the New England Journal of Medicine and just recently updated by us in the Journal of Clinical Oncology. My good friend and colleague Leah Palumba and Ranjan Advani played seminal roles in us running this trial. And now we have about 5 years of experience on average for the patients that were entered. And what did we learn? Well, 90% of the patients actually responded. These were heavily pretreated patients, 40% of whom had a prior that were refractory, meaning they didn't respond to their previous therapy. And yet, 90% responded, 80% got a major response. But you can see to the right that depending on what your genomics were, made a difference. If you had no MYD88 mutation, you didn't really respond. You didn't get those major responses. And if you did have the MYD88 mutation alone, you did terrific. Almost everybody had a major response. Half had a very good partial response, which means that at least 90% of their IgM went down, which is a marker of disease burden. And these mutations happen very fast, on average about 1.8 months into treatment. But if you had the two mutations, the MYD88 and CXCR4, you see that the responses are still good by our traditional standards of looking at other chemoimmunotherapies, but you see that the depth of response is much less. There were only 9% very good partial responders versus 47% if they didn't have the CXCR4 mutation. And it took longer. It took almost 3 months longer to get into those major responses. Now let's take a look at the next slide, and you'll see that the responses actually last for a long time with ibrutinib, that at 5 years, 54% of the patients did not progress, 87% were alive. Now look over to the right, and you see in that other diagram that the patients who had only the MYD88 mutation did the best. 70-ish, 75% of the patients at 5 years saw no progression, versus 38% if they had also the CXCR4 mutation. And those patients that had no MYD88 mutation progressed very, very early on. And so this tells you that the mutation status not only tells you the depth of response, but it also tells you about how long those responses would last. Now, what we also learned with the longer follow-up was there was more atrial fibrillation. About 13% of all the patients had atrial fibrillation, but most continued on therapy with medical management. And that 13% includes also grade 1s, which for most patients tends to be relatively asymptomatic. Now, we also ran a trial of ibrutinib by itself in patients that had no prior therapy. And these were all MEDIATE mutated patients, and everyone responded. 87% had a major response. But if you look there towards the left lower diagram, you see that there were fewer of those very good partial responders if you had the CXCR4 mutation. So again, the depth of response was affected, so was the time to the response. The major response time on average was 7 months if you had the CXCR4 mutation, 1.8 months if you didn't. And you see now to the right, lower diagram, that this also impacted progression-free survival, that you were more likely to stay in a response at 4 years. And in fact, 92% were still in a response at 4 years if they had no CXCR4 mutation. That's what wild type means, versus being mutated for CXCR4, where it was 59%. Again, good numbers overall, but it shows you the difference based on CXCR4. And that's why we're after CXCR4 these days. By giving a drug that actually can block CXCR4, we hope to neutralize its effect on responses to drugs like ibrutinib as well as zanubrutinib. Now, there was also another trial I just want to briefly comment on. It's a big trial called the INNOVATE trial. It was multinational. And here, ibrutinib was given with Rituxan and compared to placebo plus Rituxan. I just want you to come away with the idea that those deep responses were once affected if you had the CXCR4 mutation. And once again, the CXCR4 mutated patients tended to progress sooner. So, big question here is, again, with BTK inhibitors being so active, what should we give in the frontline setting? Are we better off with a BTK inhibitor, or are we better off with chemoimmunotherapy? And this study, which was done by my colleague and friend Jithma Abakun at the Mayo, actually did a wonderful job. It put together centers for the study across North America as well as Europe. We also participated, as you can see there, with my colleague Jorge Castillo and myself being co-authors here, along with co-authors and co-investigators in Europe. And this was a study meant to address whether you're better off with bendamustine, Rituxan, or ibrutinib as primary therapy. I'll tell you, you can read the study any way you want, but the upshot is patients did just as well with a BTK inhibitor as they would have if they'd gone on and gotten bendamustine or Rituxan. The progression-free survival, overall survival was no different, though more patients tended to get into those complete responses if they got bendamustine plus rituximab. So at the end of the day, getting a BTK inhibitor up front, you do just as well as bendamustine Rituxan. Maybe there's a reduction in risk of these side effects that we're worried about, including secondary cancers, which we sometimes worry about, especially among young patients, in the context of using alkylating drugs like bendamustine. Now, which BTK inhibitor and for which patient? This is actually becoming a more and more interesting question. You've heard a little bit about zanubrutinib, I'm sure, in the last couple of days, including this ASPEN trial, where patients who had the MYD88 mutation were randomized to get either zanubrutinib or ibrutinib. And then there was a small cohort of patients who did not have the MYD88 mutation that went on and got zanubrutinib. And what did we learn in this study? Well, we learned that over time, there were more deeper responses associated with zanubrutinib versus ibrutinib, but the major response rate was identical. We also learned that there were some differences depending on the underlying mutations. Patients who had no MYD88 mutation actually responded. In fact, almost 2/3 of them had a major response. It's not as high as you see with people who have the MYD88 mutation, but nonetheless, this is a population where we saw no major responses with ibrutinib. And there's also some very intriguing data that you'll see among CXCR4 mutated patients, particularly, their depth of response and even how long these responses last, that favors zanubrutinib. The overall survival differences at this point are still negligible between zanubrutinib and ibrutinib. They're not statistically significant. And so in due time, we'll see whether or not the use of zanubrutinib offers even a overall survival advantage over ibrutinib. But the one thing that's very notable from the study, this Aspen study, is that the side effect profile is very different. There were far fewer atrial fibrillation events associated with zanubrutinib, fewer diarrhea events and high blood pressure events, but there was more neutropenia, meaning the white blood count coming down, associated with zanubrutinib. Despite this, there was no infection differences, as you might have expected with somebody, having lower blood counts. So I know this is a little bit hard to read, but I want you to come away with the idea that when we think about BTK inhibitors, with all the data that we have in front of us today, there are differences in the way we choose. If you're thinking about convenience and compliance means people taking their drug on the schedule that they've been prescribed. Ibrutinib might be, considered here because you have to take it once a day versus zanubrutinib that you can take either twice a day or once a day. The FDA actually approved both ways of giving zanubrutinib. The Aspen trial, however, was done with zanubrutinib being given twice a day. However, there is a report out there from Dr. Judy Trotman that was published in Blood that showed that you can give it once a day, and in fact, the efficacy as well as the tolerability are very good. And so this is one of the reasons why I think this becomes, a debate these days, is how to give zanubrutinib ideally. Now, if you need somebody to get a deeper IgM response, let's say somebody who's got, that nasty, very bad IgM neuropathy, you might think about a drug like zanubrutinib where you can really beat down that IgM level. If the Waldenstroms has gotten into the central nervous system, into the brain, we have a lot of data now that shows that ibrutinib is an excellent drug for treating this complication. If somebody has a history of arrhythmia or bleeding, you might factor zanubrutinib in because we see such a lower risk with arrhythmias and with bleeding. Conversely, if somebody's blood counts are very, very low or they're neutropenic, you might think about ibrutinib. And then those populations that we talked about, those that have no MEDI8 mutation or who are CXCR4 mutated, here you might think about zanubrutinib, although one other alternative is to add in rituximab to ibrutinib. Now, let's say somebody's not tolerating the therapy well. Well, there's data from Dr. Shana Sorosiak to suggest that you can actually decrease the dose of ibrutinib and not lose anything. But there's also beautiful data from Dr. Mazar Shadman showing that you can switch over to zanubrutinib and the patients do just as well. And so what I want to do now is I want to take a few moments to just talk about these studies. I think they're very important. This is Dr. Sorosiak's study. It involved almost 400 patients who got ibrutinib. A quarter of them actually required at least one dose reduction. The median time to that first dose reduction was about 7 months into therapy. And the upshot is it was more necessary in older versus younger patients. And despite that, nearly all the patients still maintained their hematological response. This is Dr. Shadman's study, which included Waldenstrom patients. And what he actually taught us is you could give actually the zanubrutinib if somebody was intolerant to ibrutinib or acalabrutinib. You could actually give it to them either once daily or twice daily, and you can see that those side effects get reduced. In fact, out of the 10 people who had atrial fibrillation on ibrutinib, 9 did not recur, and only 1 recurred at a lower grade. So it does show you that we can even swap out, zanubrutinib for somebody who is not tolerating a drug like ibrutinib or acalabrutinib. And I just want to anecdotally actually share with you one case why this is so important to know about all these other drugs that are available. I have a patient that I've had the privilege of managing with my colleague Jorge Castillo. And this was somebody who did, extraordinarily well on ibrutinib for a very long time, but ended up with some side effects, problems with joint pains and muscle aches that prompted to change to to zanubrutinib. And this was after dose reduction of the ibrutinib. And then this patient went on and got zanubrutinib and, continued to have a response, but now ended up with another side effect, rash, which had, that this person did not have while they were on ibrutinib. And the rash, unfortunately, prompted ultimately a switch again from zanubrutinib, this time to acalabrutinib, where the rash did not recur. And this just shows you why having these drugs is so important, because it does give us the chance to move from one BTK inhibitor to another when in fact sometimes we encounter side effects. And I think this is really a gift to the field. And of course, there are more BTK inhibitors that are being developed by the day. Now, venetoclax, also very important drug. My colleague Jorge Castillo led this study. I was the senior author for this. It was published in the very prestigious Journal of Clinical Oncology. What did we learn? This too, very active drug. It inhibits BCL2. We predicted that based on preclinical work that was supported by the IWMF in our laboratory that showed the importance of BCL2 in Waldenstrom's, and even BCL2 being able to sensitize cells to drugs like ibrutinib. And what Jorge showed us here is that patients who even got a BTK inhibitor could have, a very nice response to venetoclax. And in fact, the median response rate was 80%, and CXCR4 mutations did not affect how these patients did. So again, it goes to show you how the genomics are even paying off here. Now, what we see occurring with drugs like ibrutinib and zanubrutinib and acalabrutinib is that many patients, particularly those with CXCR4 mutations, tend to progress because they develop a mutation in BTK itself. Such that the ibrutinib or zanubrutinib or acalabrutinib can no longer bind to BTK. And this was very nicely shown by Dr. Lian Zhu when she was in our group, and this was published in the journal Blood. And subsequent to that, Dr. Jiaji Chen did a very nice study, also supported by the IWMF, that identified, remember we talked about ERK? He showed that if you had the BTK mutation, this ERK molecule became activated in the Waldenstrom and other cell lines that had the MYD88 mutation. By the way, this was a fabulous team. It was Jiaji with his mother, who actually did all this pivotal work in our laboratory. And more recently, Manit Munshi, along with Dr. Guang Yang, supported by, Dr. Zach Hunter and others in our group, showed that if you take this drug pirtobrutinib, which is a next generation BTK inhibitor, you can actually shut down ERK-related activity. And this actually kills those Waldenstrom cells. And so we now know about pirtobrutinib being also active in Waldenstrom patients. And in fact, having very high response rates, even in those patients that saw a previous BTK inhibitor like ibrutinib or zanubrutinib or acalabrutinib. And this is why we're excited about the ongoing progress of BTK inhibitor development, again, made possible because of what we know about the genomics. Which leads me really to the last point I want to talk about. And that is, how helpful are the genomics in being able to make clinical decisions, and where do we go from here? Well, a lot of people follow the NCCN guidelines. This is a guideline that Medicare follows for reimbursement. It now includes ibrutinib and zanubrutinib as category 1 recommendations, the highest recommendations they can give in patients that, are treatment naive and need treatment. This has also been included now in previously treated patients, again, category 1. Acalabrutinib is also included as another recommended regimen, and venetoclax has recently also been added to this list. This is on top of all the chemoimmunotherapies that pre-existed. Now, there are different guidelines. You saw that in the NCCN, there's a dialogue around getting MYD88 mutations in CXCR4 to help clinicians. However, there's also now guidelines, including the one recently published by my friend and colleague Maury Gertz, that says, well, you don't necessarily need to look at the genomics if you're thinking about using, therapy in somebody that has particularly very symptomatic disease, go to zanubrutinib without needing to discriminate among the IBs. Or conversely, use bendamustine plus rituximab. And a very similar line of thinking is also incorporated into previously treated patients who now need to be treated. On the other hand, you might be able to be a little bit more specific about addressing a particular patient's genomics. And this is actually the guidelines that we tend to follow in our practice, where we actually do, in fact, sequence patients out for MYD88 and CXCR4. Those that have only the MYD88 mutation, we tend to prioritize a BTK inhibitor because of the data that we already just saw. Patients do extraordinarily well with a BTK inhibitor in the frontline setting, and you don't need to expose those patients to risks associated with chemoimmunotherapy. If they're double mutated, and this is about 30 to 40% of all Waldenstrom patients, then the key question is, do you need to treat right away? Because there are patients who have like severe hyperviscosity that you need to treat and get their disease under control. This is a population where you may not want to give a BTK inhibitor up front because it takes time. We already showed that it takes many, many months to get that disease under control. But if you're not in a rush for getting a response in these patients, then either zanubrutinib or ibrutinib plus Rituxan can be considered. And those patients who have no MYD88 mutation, well, we see no activity for ibrutinib in this population. This is why zanubrutinib would be appropriate, or you can think about bendamustine or a proteasome inhibitor-based therapy like bortezomib. Now, in the relapse setting where a patient's disease has come back and you need to treat, we follow much the same thinking, except now we also have venetoclax to use in somebody who has, who now needs therapy after seeing a BTK inhibitor. Now, I talk about these mutations, but I also want to talk a little bit about the challenge. If you're getting your MYD88 tested, use PCR. Many of the hospitals these days use next-generation sequencing. It's a different platform, but you can miss a lot of patients who actually have the MYD88 mutation. And so, in fact, in this comparative study that we published last year, 1 in 3 patients who really had the MYD88 mutation were missed by next-generation sequencing, particularly those that had very low disease burden. With CXCR4, the news was even worse. In fact, 2 out of 3 got missed by next-generation sequencing. There is now really a move to try to improve the type of next-generation sequencing that's being used to include things like bidirectional sequencing and molecular barcoding. These are perhaps fancy terms to talk about today, but it does show you how you can actually even improve on next-generation sequencing. But for patients who particularly have low-volume disease in their bone marrow, it's not uncommon for CXCR4 mutations to be missed. I want to switch and just talk as we wrap up here about multi-omics. I did promise to talk about this today. And so far, what you've heard me talk about is genomics, where we actually have looked at mutations in the DNA itself, in the genome. However, as you can imagine, our regulatory capacity around the genome is quite complex. It's not just about, having DNA out there. The DNA, of course, gets coded into RNA. The RNA becomes protein. You probably remember that all from your basic biology. But all of these are highly regulated mechanisms, which is why it's so important to study them. And this is where the IWMF, along with the Waldenstrom's Foundation of Canada, have provided us with grant support that is now enabling us to look at these other very important regulatory ways that the genome is actually tooled. And so when we talk about the epigenome, which is part of this multi-omics, what you're actually talking about is the software that runs the computer. You can think about the computer being, your genome. It's only as smart as what software is in it. And this is a very complicated mechanism. We've been deciphering out the software that's actually driving the genome. And I can assure you, what we've learned so far is the software is very different between Waldenstroms and healthy cells. And the more we dive into this, the more intrigued we are, because the coding that has allowed for the likes of the MYD88 mutation to expand and become the malignancy that it is, has been enabled by the epigenome, by all the coding, the software that's gone into enabling that MYD88 mutation to take off. And this, of course, then leads to the coding of the RNA, which we've also been studying at great depths. We published a few years ago a very detailed paper looking at the transcriptome, the RNA, how it's expressed in Waldenstrom cells compared to healthy donor cells. But now the story gets even more complicated because, when you code for RNA, there are actually many isoforms that you can code. And we've actually been able to depict specific isoforms that segue along with the disease characteristics of Waldenstroms. And very shortly, we'll be publishing or presenting some of this data at the International Workshop on Waldenstroms, and I hope also at the American Society of Hematology. And what does RNA do? Well, RNA, as I already mentioned to you, becomes protein. And this too, as we're finding out, is a very involved, area for study, because there are many different ways that proteins get regulated. We already know that from, the likes of some of the proteins that I presented to you earlier, which, are enabled because of mutations. And so we're trying to better understand how we can target these with therapy. And I think some of the work that I'm hoping to see this year at the International Workshop on Waldenstrom will go one step further and talk about the metabolome, which is, how these proteins actually function and what opportunities we have in order for us to be able to target these therapeutically. So by integrating at least some of the levels of these omics, I want to share with you some breaking news, which I think is very exciting. This is actually a study we're going to be presenting at the International Workshop on Waldenstroms, and it's been submitted to the American Society of Hematology. You're the first to actually see this, so this is why this is very exciting. But I also want to tell you, this has been the work that came out of the 300 project that the WCF as well as the IWMF have been supporting. I want to tell you how big this project is. It involves 300 Waldenstrom patients who have been sequenced at all these different levels that I just talked about. Their genome, their epigenome, their transcriptome, and even further down with some of the work that's being done now by us to look at chromatin regulation and other aspects of their protein regulation. And these patients have been followed for many, many years. In fact, on average, 7.5 years of follow-up. So this has given us an opportunity to see how these patients do over time and how they do in response to the therapies that they've received. And so what have we learned so far? What we've learned is that there's really 3 big baskets under which Waldenstroms can be classified. That when you think about the individual patients with Waldenstroms, these can be patients where their disease looks more like a B cell-like lymphoma, or a plasma cell-like lymphoma, or neither of the above, and represent evolving disease, which eventually will take the form of either B cells or plasma cells. Let me back up 1 second by saying that when you think about Waldenstrom's, it's a B cell lymphoma. And B cells become plasma cells over time if no one did anything, to upset them. But in the case of Waldenstrom's, it looks like, one segment of the disease looks like, the B cell traditional lymphoma. The other looks more like plasma cells, the kind of cells that we would see in the disease multiple myeloma. And then, there's this group of patients who fit neither, but ultimately, as we see now, because we have this long time ahead of us that we've been following these patients, it looks like they're going to evolve into one group or the other. Now, why is this exciting? Because when we, in fact, look at the underlying genomics, we can see some very interesting things. The people that are B cell-like, these are the patients that tend to be the ones that tend to be CXCR4 mutated. They tend to be symptomatic. They need therapy. The ones that are plasma cell-like tend to be symptomatic, much fewer CXCR4 mutations, but they have another variant, which we see a lot in Waldenstroms. In fact, half the patients are missing a piece of their chromosome 6. These are called 6q deletions, and there's a lot of machinery that exists on this particular chromosome that regulates BTK inhibitors, that regulates, BCL2. This has been reported by us in various recent publications. What this 6q actually contains that's very important to the growth and survival of Waldenstroms. And as I alluded to earlier, the third group appears to be the group that is, composed of fewer patients, and the fewer symptomatic patients. And so this gives us the ability, when somebody is diagnosed, to actually factor in how likely they are to be symptomatic and need therapy. This is one of the reasons why we're excited by this sort of multi-omic approach to the disease, not just looking at it, in 2 dimensions, but looking at it in these 3 dimensions. What I'm also very excited about is that by using a very special technique called pseudo-timing, and this was actually very nicely worked on by Zach Hunter in our group, you can actually see a gene signature that will show you how the disease is going to evolve over time. And this sort of pseudo-timing has allowed us to actually follow patients to show what the genes are that get turned on that lead to more bone marrow involvement, higher IgM, more spleen involvement, the decreasing of the blood counts, the decreasing of the other good antibodies. Why I'm really excited about this is it's also gives us the opportunity to inform targets to block Waldenstrom progression. This, I think, will give us specific genes and targets that we can actually innovate drugs around that will, potentially can help us stop the disease from progressing into a symptomatic Waldenstrom's macroglobulinemia. We have to give great credit to Zach as well as Chris Richardson, who's also been recently recruited to our team, who have really brought incredible computational science genius to our ability to help translate these very important findings. And I just want to show you here where I think, this is paying off. We will be reporting this study. In fact, it got accepted to the International Workshop on Waldenstroms, which will be at the end of October. And it's also been submitted to the American Society of Hematology. I talked to you a little bit about some of the challenges that come with being able to detect some of these mutations, CXCR4 in particular. When you look out there at various laboratories, very few are actually able to deliver on doing an accurate CXCR4 assessment. But maybe there are new protein targets that you can easily look at, by pathologists. And this is where multi-omics have, again, paid off in a very, very big way. This is a trial that we ran, which I just showed you the results earlier, of ibrutinib by itself in patients who had not been previously treated. And I showed you, in fact, that CXCR4 made a difference in terms of how those patients responded. But what we ended up doing here is actually apply multi-omics to look and see if there were particular protein targets that identified the patients that were most likely to respond to ibrutinib. And by inference, maybe all of the BTK inhibitors. And in fact, we found some very important ones, which are easily accessible. When these patients have the bone marrows done, you can actually take the bone marrow biopsy and stain for one of these proteins, and it will give you this sort of target identification that may predict the patient that's more likely to respond to ibrutinib than not. And this is why I'm excited about multi-omics, because it does give us the opportunity to identify novel biomarkers for predicting responses to drugs, including, in this case, to ibrutinib. So I just want to wrap up here by saying that, we have, still a number of unanswered questions to which we're getting answers. We've learned, from these studies that the drugs that have been enabled by genomics, have in fact, delivered on very effective BTK inhibitors such that they rival the activity of chemoimmunotherapy, but perhaps reducing risk associated around some of these drugs. And I also, pointed out the importance of genomics as well as patient-specific morbidities into making these treatment decisions. With regard to which BTK inhibitor and for which patient, I think, all in all, come away with the lesson that if you have the MYD88 mutation, it looks like in aggregate, you tend to do better with BTK inhibitors. One should keep in mind that there are a number of risk factors such as atrial fibrillation, bleeding, as well as neutropenia, which we factor into our decisions as to whether we employ a drug like zanubrutinib or we employ a drug like ibrutinib. Keep in mind that the genomics also are very important. We tend to favor now zanubrutinib for patients that have no MYD88 mutation. Those that are CXCR4 mutated, we will favor zanubrutinib or add in rituximab to ibrutinib, and that's when the patient doesn't need, an immediate response. Keep in mind also that, the genomics have informed us as to how to treat patients who are either intolerant or progressing on BTK inhibitors. We now have a family of BTK inhibitors that can be used for switchover. And also think about venetoclax, another very important drug class that now is available based on NCCN addition. And then the last thing I just want to come away with is genomics are important in treatment decision making. I think more than ever, getting somebody's MYD88 and CXCR4 mutation status is important. PCR should be used for MYD88 detection. And multi-omics, which I think ultimately are going to fuel the fire for new drug development and our ability to identify biomarkers for predicting disease treatment response are in the are in our short-term future. And with that, I'm going to just wrap it up here and thank once again my colleagues and friends at the IWMF for all their support and for giving me the opportunity today to share all this progress with you. And also to my Canadian friends and colleagues, including Paul Kitchen, for supporting much of the genomic work that has also enabled a lot of the progress that I was able to share with you today. Thank you very much.
Wow. Steve, it's so exciting to hear the latest research and all that you guys are doing, and it's just so exciting for us WM patients to know there's so much coming down the line, and it's great. There's a bunch of questions that are lined up, so Steve, if you don't mind, maybe we should jump into answering as many as we can in the next few minutes.
Very happy to, Paul.
Okay, let me pop them up here. First question is, please discuss the current state of research for those of us who have TP53 and MYD88, but no CXCR4 mutation.
Yeah, well, I think this is a really good question. First of all, the TP53 mutations still are relatively rare in Waldenstrom's. In contrast to CLL, where they tend to be more common and predictive. In our experience, we usually see TP53 with MYD88 and CXCR4. These tend to cluster together. And the TP53 mutation is important to know about because it actually regulates a lot of the machinery that prevents, ongoing DNA mutations. So when you have a mutation in TP53, you're sort of getting rid of the guardian of the genome, so to speak, that actually would prevent other genomic mistakes from happening. So patients that typically have these mutations tend to have a lot of mutations. But as I said, in Waldenstrom's, also including the CXCR4. Now, some TP53 mutations tend to be, more bigger offenders than others. And so it's important to know which TP53 mutation we're talking about. But patients actually, whether it's Waldenstrom or CLL, tend to respond to BTK inhibitors. In fact, in the CLL world, they tend to prefer the use of a BTK inhibitor for those that have, these TP53 mutations. And our experience, as well as others, is that they're also very important and very active drugs in Waldenstrom patients that carry TP53 and MYD88.
Thank you. Next question. How would you treat someone who had MYD88 wild type and some CXCR4 frame shift mutations and presents with hemolytic and anemic/cold agglutinin disease?
Yeah. So I'm going to just say right off the bat, I hope I'm not going to give specific medical advice today, because when you don't know the whole story of a patient, you're really out on a limb. But I'd like to just take this question and sort of talk about it in generality. Again, because there's a lot of details you need to know before you can say, how am I going to treat a specific individual? First, we want to make sure the patient really is MYD88 wild type. And again, wild type meaning there's no MYD88 mutation. Was this determined by PCR or not? That's really important to know. And there are patients who have no MYD88 mutations and have CXCR4 mutations, but these tend to be also fairly rare, which is why I would want to make sure that the MYD88 testing was done correctly. And this is really important because otherwise, we would probably favor using a BTK inhibitor with somebody who's presenting with cold agglutinin disease. But if they don't have the MYD88 mutation, the responses might be less. One might want to think about zanubrutinib, because we just talked about, the activity of that drug in somebody who doesn't have the MYD88 mutation. The responses aren't as high as we see in somebody who does have the MYD88 mutation. So you want to make sure that that's correctly done. But the art here is get that IgM down. I'm presuming here it's cold agglutinin disease based on what the questioner has asked, but being able to get the IgM down is what's important. And so one can think about, the likes of using rituximab alone, or bendamustine and rituximab together, or a proteasome inhibitor such as bortezomib with rituximab and steroids together. Which one of these drugs you would use, or zanubrutinib, would come down to the patient's specific needs and genomic characteristics. And so I just want to make sure that this patient truly has MYD88 wild type. But those would be some of the options that we would talk about.
Okay, thank you. We don't have much time, Steve, so maybe maybe two more questions. Okay, the next question. I've just started the nebtrib clinical trial,
Nemtabrutinib.
Can you provide any information to how patients are responding to this new drug? Can you provide any information to the advantages, disadvantages of this drug?
No, it's a great question. Nemtabrutinib is also one of those non-covalent BTK inhibitors. And just for the sake of everyone, the BTK inhibitors are divided into two different classes. Those that bind covalently, meaning they form an irreversible bond, and those that are non-covalent, which can, bind to a molecule but unbind, and then bind and unbind. And so there are particular, drug concentration characteristics that favor binding over unbinding. Nemtabrutinib is actually made by Merck. It's a very exciting drug. It also inhibits HCK, which we're also a little bit excited about because it offers an additional advantage, because HCK is also an important target. But this is still in trial. So it just, we need more experience. Unfortunately, we're still at the beginning, and I'm really glad this individual is participating in the clinical trial, because that's how we're going to get the information to enable ongoing development of this drug.
Okay, and we're going to squeeze one last question in. Thank you. Will a peripheral blood sample eventually replace a bone marrow biopsy to test for MYD88 and CXCR4?
So the answer is yes, I think so. You can, in somebody who has not been treated yet, your chances of picking up the MYD88 mutation on a peripheral blood sample are very, very high. In fact, we did that study, published it many years ago in the journal Leukemia, thanks to the work that Lian Zhu did. CXCR4 is a little bit trickier. But, even though I said that NGS is the preferred modality, we're now focusing in on those nonsense mutations that I mentioned earlier are the bad actors. Those we can use PCR, and we can pick them up in the blood as well. And even more exciting is the use of cell-free DNA. All that means is you don't need cells anymore. You can just take the blood sample, and in the blood sample, there's floating DNA that you can also sequence. So I think the answer is absolutely. We're slowly getting there, but we will get there.
Steve, we've used up all our time, so I thank you. There's a whole lot more questions, obviously, as there always is with you. As always, it's so enlightening, and for all the breakthrough science and everything else, it's so much to think about. I know everybody appreciates you answering questions so directly, and incredibly grateful for all the sharing that you do with the WM community, and the IWMF appreciates your friendship so much. Just in closing, I'd like to extend the gratitude for the Ed Forum's title sponsors, Beijing Pharmacyclics Janssen, as well as Celatar Biosciences and the Treadway Foundation and X4 Pharmaceuticals. Please stay tuned, because Dr. Treon will be back for Ask the Doctor question and answer panel coming up. Thanks, Steve. Thank you all for listening. Just before you go, there's one last little. To view our next session, close the current webcast window and navigate to the theater tab at the top of your screen. Then select Live Now button, and you'll be able to move on to the next session. Thank you all very much. We appreciate your participation.